So, what would you like to start with? The A's, the B's, or the C's?
I don't know.
Start with the A's?
Sure, let's
go for
take
it.
it from the top.
Okay, so what I have here is your biometric information. This was done on that biometric scale where you have the two arms and the two legs, and then what it does is it sends a bioelectric impulse, and then it tests how much fat and lean muscle is in your arms, in your legs, and also in your midsection. Okay, so.
And I guess I didn't fast. I didn't get the fast message.
Right,
so,
exactly. Yeah. So this isn't exactly perfect, but it's pretty close enough. So let me just do dry lean mass 30.9 divided by 145. Dry lean mass 21.3. Okay, great. So when I look at your numbers, they look pretty good, actually, extremely good. Your percent body fat is 21.9. Okay, that's pretty good, actually. That's extremely good. For a man, less than 20 is the target. For a woman, less than 30 is the target. But a target is a little confusing because there's normal and then there's optimal. I don't think we know yet exactly what the perfect percent body fat is for Alzheimer's prevention or risk reduction, but what I would say is that you are doing pretty darn good. 21.9 is great. Okay, is that elite, meaning are you like an elite athlete? Well, no, I'm not going to say you're an elite athlete, but that's pretty good. When you take a 57-year-old woman with a percent body fat of 21.9, that's excellent. That's in the top. We have a lot of very fit people in the clinic, but that's still in the top 20% of the clinic, maybe top 15%.
I don't self-identify that way at all. So.
What do you mean by not having low body fat?
Yeah, like I think of like, oh my God, I'm like the menopause overweight. I'm in this like horrible struggle and like, and so this was the part that really terrified me.
Well, the
I'm
part
sure you have
about
some bad news.
Not necessarily. The part about your body fat that's good news is that it's not heavily located in your trunk or in your viscera. So what is, for example, your waist size or your dress, or I guess do you know your waist size when you're in college?
Oh, in college, I used to be like I was 27, because I was like 36, 27, 36 was my thing for a long time. But then I went through a phase in life, like earlier, like actually right around college. That was after college. Like right around college, I was like kind of big for a while. Like after I probably weighed like 25 pounds more, and then sort of lost it. After that. So that then for a long time in my early adulthood, that was like what my size was. But then I had 4 kids, and every time I had a kid, I gained like 50 pounds in pregnancy. Then I would lose it all, and then I would have it again. And this was 4 times within 7 years. So I have a lot of like, body issues, like, anyway. And then, after menopause, and it's like, oh my God, then I'm aware it's like it's harder. It used to be I could, gain 50 pounds in pregnancy and lose it, and then, but then it just got harder and harder. So I feel like I really have to like work at it now, but I'm like worried I'm not like working the right way. Like, am I, I don't know. Like, is it muscle? Is too much, is it enough of the right kind of muscle, and those kind of questions.
Okay. Well, we're gonna go through that. I've identified your problem area. Okay. The good news is you have good news. The other news is there's some stuff that we can optimize, because the concept of prevention, right? Usually when we talk about treating a disease like Alzheimer's, we're treating a disease. The concept of prevention, being in a preventative medicine environment, is different. You have normal, you have abnormal, but then you have optimal. And the concept that these numbers may be normal, and actually these numbers are pretty good. These numbers are better than normal. Body fat, 57-year-old woman, 21.9, high five, you're doing great. But 20% would be phenomenal. That would be optimal. Does that make sense?
Yeah.
Your lean mass. So your lean mass is your muscle mass. How much of your muscle is dry lean mass? It's actually pretty darn good. It's 21.3. That means 21.3% of your body weight is lean muscle. That absolutely has to do with your nutrition. You eat clean and you eat lean. Your Pilates and your core training, that has to be part of this. You're doing lots of walking, which is good. But what I can do is I can recommend a little bit of a modification in some of your activity after I look at your labs. Let me see what your labs show. Because one of the really important points here is, as we go back to this little diagram, I'm not going to make any major recommendation to change what I tell you to do without triangulating all three of these pieces of information.
So they all work together.
They 100% all work together, because maybe 21.9, maybe it's not 20%, which is like pretty optimal, but this is totally normal. But if I look at your labs and your labs are pristine and your cognitive function is pristine, then I'm not going to really worry about that, and you can hang out at 21.9 and not need to do anything about it.
But if I was on the border of other things not looking so good, then I would really want that. I would want to be more optimal.
Exactly.
Right?
So when I talk about percent body fat is all about metabolism. Metabolism, body metabolism. I'm going to look at your blood sugar, your fasting insulin, your hemoglobin A1C, which is your average blood sugar over 6 months, your fasting blood sugar, which super important too. We're also going to look at your memory measures, because memory and metabolism often go together. So what we're going to do is we're going to triangulate all three before I make any recommendations. What I do see from this is that while you are you're a righty. Are you right-handed?
What?
Are you
Right,
right-handed? Okay. Your right side, your right arm, and especially your right. Have you ever had a left leg injury of any sort?
Yes.
What'd you do?
I had not an injury, but I had the Morton's neuroma.
Okay.
And so I've had surgery on that.
Okay. So I can see that a little bit. Your right leg is by far the strongest part of your body. Your right leg is really, really, really strong. Your left leg is strong, but a few percent less strong than your right leg, and that's probably due to the Morton's neuroma. Your arms are much less strong than your legs, even though your arms are reasonable. Your trunk, actually, your chest and your core is actually the least strong of your body.
You can tell that from that.
Yes.
Because literally I've been doing all these other things and I never did any core, and then my stepson's like into all this, and so I went to the gym with him and my husband and they were showing me core, and I could not, I didn't have a core, I couldn't even find those muscles. So that's interesting.
Yeah.
You can
And
tell
that's
that.
and you're getting close to being expected for your age, but your core is the only part of your body that is less ideal than your expected age.
Yeah.
It's now your legs are actually pretty close to optimal, and your arms are somewhere between normal and optimal. So it's all gradiated that way.
That's interesting. Okay.
And the key here is, why does this all matter?
Yeah.
Well, it all matters because I mostly care about visceral fat. What did you say was your waist size now? Did
They
measure
just
it?
measured me, and I don't know what I said, but
I'm
it's
sorry.
31 when
31.
they did it.
Okay,
Yeah.
so you're a couple of inches bigger than you were in
Yeah.
high school, and you, for women, that's easily okay. But maybe we can tighten that up a little bit, a half an inch. But I don't think your waist needs to be less than 30 inches. I don't think that's going to affect you negatively in terms of your Alzheimer's risk. The other part about this is your blood pressure looks good, 135/75. And if you look at the new blood pressure guidelines, you're right in range there. So you're right. Actually, that's normal. Actually, closer to optimal than normal. And your resting heart rate is great. Your resting pulse rate of 53 means you're means you're in good shape. And resting heart rate is tied to longevity, and I think it's also potentially tied to Alzheimer's risk, although we haven't really figured out our data yet when it comes to that. What we do in our clinic, we have a sub-study where we use these biosensor bands, where we track sleep. We track REM sleep, deep sleep, total sleep, and we also track exercise strain, resting pulse, cardiovascular recovery, things like that. So we're trying to use these sensors at home so we can really understand body function, which actually gives you a window into the brain. So, but at a baseline, your heart rate of 53 looks pretty good. So, okay, so that's your A's. If I had to give you a grade on your A's, you get an A for A. You get an A on your A. Okay, let's talk about blood. So blood biomarkers is, there's no one magic lab or one magic number in these tests that are going to, be able to tell me one way or another what your Alzheimer's risk is. Again, we take it all together and we combine it and we try to figure out what we can do, how we can intervene. So I'll show you a couple of things. So we're going to start off on the first page. We're going to be looking at cholesterol results. Okay, so let's start off by looking at your cholesterol. Okay, so your cholesterol results, your total cholesterol is 222. And here it's yellow, but that's pretty reasonable. I don't actually care much about the total cholesterol. I care much more about the subfractions that are down here. You can look at the things too.
Not on that?
No, yeah, you can. Oh, yeah. You can get the numbers.
Oh.
Yeah. Cool. And we'll blur out the name. So your total cholesterol is 222. Okay. Sure, it's above 100, but I don't exactly know what that means. Your LDL, your low density lipoprotein, that's your bad cholesterol, isn't, it's in the close to normal range, but it's not optimal. Okay, and that's interesting because you eat so cleanly, so I'm a little confused why that would be. Your HDL is excellent. For a woman, 82 is very good, and this is probably a protective factor. And your triglycerides are 71, which is also excellent. So I don't think the wine, for example, is harming you or that kind of thing, but I'm not 100% sure why your LDL is a little bit higher than it could be. Again, I'm not going to tell you to do anything about that until I look at everything else, because one of your cognitive measures is something that I'm going to be very interested in.
I was just going to say what are reasons, but you're going to reveal that to me.
Yeah, we'll get there.
On.
So when it's going to be a strange question, but are you more like your mom or your maternal grandmother, or are you more like your dad?
In terms of?
Just gestalt.
Oh, I'm way more like, I look more like my dad, but I'm much more like my mom.
What do you mean? Physical.
So I physically look like my dad, like his coloring and everything, but he was like this easygoing, genial, and my mom was much more like the thinker, doer, like also more like our personalities are more the same.
What about your grandma?
My grandma was like my dad. Their personalities were similar. She was sort of this jolly, easygoing lady, but she was like the stout sister. So she had like 5 sisters, and she was the stout one. I have 2 sisters, and I'm like they're like, one is a little dancer, one is like a tall, skinny, and I was like always like the curvy sister. And so in my grandmother's family, I feel like I identified with that. But like personality, I don't know. She was a Polish immigrant seamstress. It's hard to say how I was like her.
Gotcha. Okay. Sometimes what I end up seeing in just there's genotype and phenotype. Genes are the physical expression, phenotype. I'm wondering if you're usually someone who's, this is not perfect, this is far from perfect, but sometimes what we see as a pattern is a child that is more physically like a certain parent. Sometimes that parent's medical problems manifest more in terms of brain health. And this is a little bit back of the napkin, but
right. But I would say physically, I'm like more like my dad and my grandmother, even though they're like not, those two aren't related, than like my mother. Like my mother was like this really like fine boned. I don't know. This is kind of interesting.
Interesting. So when I hear about a father with vascular cognitive impairment, and I hear with a maternal grandmother of Alzheimer's disease, late onset, something like this would be increased risk for vascular cognitive impairment later. And I mean later, so you have, again, 25 years to worry, so you're here at the right time. Or high cholesterol doesn't cause Alzheimer's disease, but it's a way to push the fast forward button towards Alzheimer's disease. And we don't want to do that, we want to put the brakes on. So we're going to now take a much deeper dive into your cholesterol, okay? Because LDL and HDL are not enough, in my opinion, to truly be able to make a qualified decision about what you need to do. And what we do is we do an advanced cardiologic panel. And when we do an advanced panel, this is what preventative cardiologists use. Your ApoB is a little bit high, and your LDLP, which is your small and dense LDL. So I'm going to draw a little picture of your blood vessels here. So this is your blood vessel, okay? This is fluffy, big and fluffy LDL, kind of like a beach ball, okay? This is a same LDL, the bad cholesterol. These are both bad cholesterol, but one is fluffy and big like a beach ball, one is small and dense. Which do you think is worse for you, even though they're both bad?
Well, of course, I would think the big one's first.
Okay, that's 95% of people think, but it's actually the small and dense one because it pings against the blood vessel wall and causes inflammation and atherosclerosis over time.
Do we all have both kinds?
We all have both kinds. You have high overall LDL, but you have slightly high LDLP, meaning a higher proportion of this than I would like. So I need to get this number down if I'm going to try to correct this risk. How do you get that down depends on what the rest of your labs show. Okay, and if we really need to get that down depends on what your cognitive function looks like. Because what we've been finding over and over is people with a cholesterol perspective like this, maybe because you're pretty close to normal. I'm splitting hairs here. Okay, this is pretty darn close to normal. Like 1,000 is normal, you're 1,028. We have people in the 1900s. Okay, so this is not, and 130, you don't need a medication for your cholesterol. This is like not medication. This is lifestyle, but you're already doing everything right nutritionally. So ways to get this down would be omega-3 fatty acids. Maybe you're eating fish, but maybe your levels are low, so we're going to look at that. And there's other ways to get it down too. The other aspect here, this is actually another lab called ApoA1. The higher this is, the lower your Alzheimer's risk. So you're pretty close to 180, but I want to get this down a little lower. So this is a marker that we'll follow over time. This is a new lab that we've basically really learned about just within the last 6 months, believe it or not. We've been checking this lab for several years, and I knew there was something to it, but now at least we have some data. And then we're also going to look at this over here. This is called the cholesterol balance test. Not all people, in my opinion, have high cholesterol for the same reason. Okay, some people have it because of a gene, some people have it because of lifestyle, some people have it because of their body's own metabolism. So for example, you are not an overproducer of cholesterol, you're an overabsorber of cholesterol. So we would, for example, with you, if your cholesterol ever starts going up in the wrong direction, a statin medication wouldn't probably be the best targeted, precision medicine approach for you. A plant sterol inhibitor may be the right choice. So there's prescription drugs called Estimbine or Zetia. We wouldn't use that in your case because it's so borderline, and we haven't tried other things like omega-3s. But again, if you're low in omega, I would predict that based on seeing this, your omega-3s are going to be low. We'll check in a little bit, okay? But if we're unable to, and you also eat very plant-based, so I do have, for example, vegetarians that have very high absorption because they're eating tons of plant cholesterol. It's not necessarily bad for them. So that's why I'm going to look at the cognitive function in a minute to see what we need to do about this.
So is this something that's bad, or this just is what it is and therefore affects other things?
Is what it is, and it affects that.
Yeah. Okay.
It's not bad in any way, shape, or form if this was a little bit greener.
Right. Okay.
And again, is this green? Does this need to be green? I don't know. Let's look at your cognitive function a little bit. Okay. Other things that we're going to look at now are inflammation. Now, inflammation, these labs aren't the best labs in the world for looking at inflammation because we can only check so many labs. Fibrinogen is one lab that's recently been shown. There was a study in neurology, actually in November 2017, not that long ago, that showed that fibrinogen is one of the inflammatory markers that predicts vascular-related cognitive loss in the future. Okay, your fibrinogen is low. So what this tells me, and what permutation that I often look at or often tell people, is that, has your cholesterol caused any negative damage? Well, if your inflammatory markers are good, probably not. There's another aspect that we can do, and I don't think you really need something like this, but it's called a coronary calcium scan. Coronary calcium scans look at the amount of calcium in the heart vessels. Some people, when they're not sure if they should treat their cholesterol, would be better risk stratified by doing a coronary calcium scan. It's a simple 15-minute test, even less than that, I think. And it's usually not covered by insurance, but any preventative cardiologist could do that. If you had a strong family history of heart disease, early heart attack, things like that, you may want to see a preventative cardiologist. Right now, I don't feel that you need to do that. But it doesn't seem like you have a family history of early heart attack in your family.
No. I mean, I don't know, my father's father died of a heart attack at like 60 something.
Something like that.
But I
So-
don't, you know, it's not like it's
No.
like a big thing in our family that people are always
Yeah.
talking about.
And you're pretty close to normal. This is me splitting hairs here.
Mhm.
I mean, this
Mhm.
is
But that's also a fairly new test, right?
the coronary calcium scan.
Yeah.
So coronary calcium scan was actually first published by Dr. Arthur Agatston
Mhm.
back in 1989
Hmm.
and 1990.
Hmm.
So this test has been out forever, but oftentimes in preventative health and preventative cardiology, it takes decades for someone's forethought to be accepted in medical science. So Dr. Agatston is one of the first preventive cardiologists, and actually he was one of my mentors when I was an intern in Miami Beach. So this was before he wrote a book. You may have heard about the book. It's called The South Beach Diet. And he was a, forward-thinking cardiologist that
Wow.
the field didn't understand how forward-thinking he was until decades later.
Huh.
Yeah. And actually, a study came out last year that shows that people with elevated coronary calcium, 20 years later, are at a higher risk of vascular dementia,
Yeah.
which makes complete sense. Even though coronary calcium scores could be high, but someone could have no symptoms. It's kind of like having amyloid in your brain 20 years before.
Right,
the
right.
same-
Because
same
I just
thing.
did this whole project with Johns Hopkins,
Mhm.
writing their like consumer-facing web portal.
Right.
It's called the Healthy Heart or something like that. And so I had to talk to all the different cardiologists, and they were excited about all these different tests and things. And it's so interesting because it's like the heart and the brain. It's like there's so much. It seems to a layperson me like there's so much overlap,
Yeah.
and so.
Yeah, there's people say what's good for the heart is good for the brain.
Mhm.
I say yes, but it's more complicated than that.
Hmm.
So
Mhm.
and it's the brain is affected very differently by different cardiovascular risk factors.
Mm.
So high blood pressure, for example, in midlife increases Alzheimer's risk later. Low blood pressure in late life increases risk of Alzheimer's and cognitive impairment. So you have to kind of change your archetype, change your mindset just a little bit, depending on which lens you want to try to look at it. Okay, so now we'll get to super important tests. These are really like the most important, I think, if I had to look at all of these, your metabolic tests. So let's take a look at these. So your metabolic tests, this is great. This is lots of greens. Your hemoglobin A1C, which is your average blood sugar over the previous 6 months, is 5.5. Now 5.5 is great, it's normal, but is it optimal? I'm not sure. For a 57-year-old woman, I would say 5.4 or 5.3 would be closer to optimal. Now, you're not going to find many doctors that are going to be telling you the same thing. Most doctors are going to say 5.5, that's great, high five. But again, it's optimal versus normal, okay? Remember I said your waist went up by a few inches since college? I'm going to look at your memory scores in a little bit. This is something you probably don't need to do much about, but if your memory scores aren't optimal, then you don't have prediabetes, you don't have pre-diabetes, but it just says that in several years from now or a decade from now, you're at risk of this number going higher. So that's why if we can maybe increase your muscle mass by a tiny little bit and increase your muscle mass in your core and decrease your waist size by maybe a half an inch, that's maybe what you would need to give yourself a metabolic boost to either keep this at 5.5 for a while or get that down to 5.4.
Are some of these things the reason why, like, age is just one of the biggest risk factors? Because it's like the more that time's going on, the more, like, I might just start slipping on that, or, people kind of let themselves go, and
Sure.
then all your markers are.
Yeah, I mean,
all
just
affected.
as an example, when it comes to muscle mass, people lose muscle mass 1% per year. So you have to gain that by doing very specific muscle building activities and resistance training. So the goal here is to outdo the age effects as best as one can do. Okay, but now glucose, your fasting blood sugar is 85. That's great. Okay, now the normal number is less than 100, and that's true. But what we're even seeing, there's actually someone named Dr. Agnes Flohl who's done some really great work in Germany. That maybe 95 should be the normal of glucose. But regardless, you're in a really great range. You have no elements of insulin resistance. Your fasting insulin is 5. Your metabolic labs look great. Your adiponectin is great, greater than 25, which is a fat hormone. We're a little confused confused about what this adiponectin means in terms of Alzheimer's risk, but we're trying to learn more about it. GSP is a little bit high, but this just means that your average blood sugar over the prior 2 weeks that you took these tests was a little higher than it was in the prior 6 months.
What is GSP?
GSP is just average blood sugar over the prior 2 weeks.
Oh.
So maybe you ate more sugar or something than usual in the 2 weeks before the labs were done. Were you on vacation?
No, but
before
after,
these?
actually.
Right after, okay. All good. Okay, and then the next page, and second to last page, I think, is genetics. As you can see here, you have a lot of greens, okay? You actually are about as normal as can be when it comes to the genetic factors that we look like. I actually don't remember the last time I had a patient. Maybe 1 out of 20 patients are this green. So what does this mean? You have ApoE3, ApoE3. Okay, you do not have an ApoE4 gene. Okay, whatever that means. ApoE3 is a neutral risk for Alzheimer's. ApoE2 is protective against Alzheimer's. ApoE4 increases risk, so you're at a neutral risk. About 55 to 60% of the population has this, and it just tells me that I know how to treat you better because of this gene. I don't use this as a risk modifying gene. I'm just going to tell you to do one thing versus another based on that.
Right.
Okay. These are some other genes, factor 2 and factor 5 Leiden. Wasn't expecting anything there. Your MTHFR gene is normal. You have no mutations in any of the genes. This means that if your homocysteine is elevated, you probably will respond to the usual B vitamins that we give, B12, B6, and folic acid. But again, we're not going to use that until we look at the rest of the labs. So you are very clean genetically. That's the good news. The other news is there's dozens of other genes out there that we haven't checked for. Okay, so at some point, if you want to take a deeper dive, we're going to hopefully have funding one day to do this. Otherwise, there's other ways to do it too. We can talk about that.
And there are genes that give you information actually at this point, or
it's
or you want to
well,
study them?
if time was unlimited and if I could spend 10 hours on every patient, I would look much more closely at a more broad spectrum of metabolic genes, Alzheimer's risk genes, and some other genes that we may be able to intervene on based on their function.
They would affect the other things in your...
Exactly.
Okay.
Yeah. Now, unfortunately, this takes long enough, and Alzheimer's prevention is complicated, so we're starting reasonable. I've had about 3 dozen patients that have done the full gene stuff, and then we've basically gone on a fishing expedition and tried to look and find some intervenable genes, but most of the time we only find a few, if any. So that's a little complicated.
Are people more likely to want to do that? People who have like a ApoE4, like if you have 2 ApoE4s, is that like, oh wow, I should do a deeper dive?
Well, actually, those people are less likely.
Oh.
Because if you have 2 E4s, maybe that explains the family's increased risk. People that are 3 3s, you don't have a super strong family history of Alzheimer's. You have one on one side, and then you have vascular on another. So I'm actually less interested in a deeper dive in your genome at this time.
Right, I get it.
What we're going to do is you're going to come back in 6 months, and then 6 months later, I'm going to see how you're responding to the therapies, and if you're not responding like I would expect, then maybe we could talk about the deeper dive.
Right.
Case to do this with. We would have had no idea. You're like a perfect case to do this with. Like you have easily recognizable risk. You have normal but not optimal, not perfect, but close to optimal. So ready to start?
Recording.
Okay. So overall, your executive function and processing speed, great, close to optimal, but I think we have a little bit of room to go. Okay, this test is your odor identification. So believe it or not, smell memory, odor identification, is a great marker for neurodegenerative disease. It doesn't mean Alzheimer's per se. It could mean head injury, Parkinson's, zinc deficiency, whatever. But your odor identification was completely normal, 9 out of 9 items, so that's perfect. That would tell me that maybe 5, 10, 15, 20 years from now, something's going on, and maybe you may become symptomatic. So that's a good screening measure too. This is a test called the oral symbol digit. I don't exactly know what to do with this test yet, so hold off. We're just doing the analyses on this metric now. We've already done the analyses on this stuff, so I understand this stuff is a good measure. We haven't yet proven about that. Your mini mental status exam score is 30 out of 30. You've probably heard of this test. It's the most commonly used test. 90% of the people in our clinic are already at a 30. This is a ceiling. Can't get any higher than a 30, right? You're normal.
What was that test?
Where we ask you the name, the date, and orientation.
Right.
So the key here is that using a test as simple as a 30-point test and not doing all these computer-based stuff is not sufficient for a prevention clinic. So that's why we do all these other computer-based tests, which isn't super fancy. It's just using a computer. Your FAS is great. This is a marker of executive function. FAS is how many words can you name starting with an F, an A, and an S in 1 minute each. 59 words is awesome, and it's in the 80th to 90th percentile, which is great. Your executive function, it's your language, ANT, your animals. This would be lower. 33 is like off the charts. Your animal naming and memory would be lower in an early Alzheimer's case. Your FAS is there's category fluency versus that's animal naming versus basically phonemic fluency starting with F and S. See, it's a touch lower than 90th percentile. You're probably like 1 or 2 words off. This is a marker of executive function. So here you're normal but not precisely optimal. Here you're pretty close to optimal but maybe a couple words off. So the next time you come in, we're going to be looking at this stuff to track your progress. Make sense? And this is how we analyze the effect of our interventions. We don't just say, oh, I think it works, or the data says it works. We're going to follow you over time, every 6 months. Your Trails B, that is lightning fast. That's a combination of executive function and processing speed, the A to B, that thing that you drew out.
Oh, I thought I did really bad at that one. No, because it had numbers.
No, you just have to be less than your age. And 36 seconds is very fast. That's very, very, very fast. Your Boston naming should be 15 out of 15. That's easy. Your learning ability, this is a 15 words, is good. You learned of the 15-4, then 8, then 12. Yeah, it's good, but not off the charts. And your delayed memory is good, but not off the charts. Okay, so I'm thinking, could this have anything to do with some of the metabolism labs? And I'm not sure yet. This is your paragraph recall. So you had 16 of 25, which is good, and 14 of 25. So your touch, you're about half a standard deviation and 0.18 standard deviation above the mean. And then your other memory tests, you're at the mean or above the mean. So your memory test, I would think, is I'm going to say in summary was normal, better than normal. Not super duper duper optimal, but pretty close to normal. So I don't think your metabolism, that average blood sugar of 5.5 and the 1 extra inch around here, I don't think that's affecting your cognitive function. I think the only thing that I can see that would be potentially affecting your cognitive function, potentially, because this stuff is very new and not an exact science yet, would be we want to try to optimize your lipids a little bit. And we can do that with the omega-3s, and we can do that with I'll just start with the omega-3s.
And so why, so remember at the beginning I asked you, like, why do people have, like, those lipids, like that lipid profile? Like, what are the, is it diet? Is it something genetic about me and lipids? Is it, like, what are the typical things?
So the term here is epigenetics. Epigenetics. So epi means environment, and genetics means your genes. So whatever you're doing in your environment, combining with your genes, is the reason why people manifest the way they do. With you, I don't know what genes you have that have to do with cholesterol that we didn't check for. Remember, we only checked for a handful of genes. Could you have another cholesterol gene or genes in there that's driving your cholesterol up? As we showed you, you're more of an overabsorber of cholesterol than an overproducer. So maybe there's a reason your body absorbs more cholesterol than the average bear. So I don't know. I don't really see too many dietary changes that you can make. I'm going to give you some things to read and some, maybe you'll notice a thing here and there, but I'm not exactly sure. So the thing that we can do to help keep you in balance is get your omega-3s back in balance, because That's not, your omega-3, your omega-6s are high, and that's good, but they're too high compared to your low omega-3s. So we keep your omega-6s the same, increase your omega-3s in your diet, plus I think you need a supplement because you're already eating fish twice a week. Then maybe we can correct some of this stuff.
And eating fewer nuts to bring the omega-6s down doesn't really
I'm not sure that's necessary.
Yeah,
I don't know
yeah.
that we know the answer for
Yeah.
brain health. I
Yeah.
know that nuts are heart healthy,
Yeah,
so I don't know
Yeah.
for brain health.
because that's probably like a big source of protein for me.
Yeah, and I
But
don't want
I
you.
didn't-
I don't,
yeah.
and it's not. They're not bad for you.
Yeah.
It's just you're not in balance.
Yeah, yeah.
Makes sense.
That's so interesting. That's the last thing I expected to hear. Wow.
Interesting.
Yeah.
So your homocysteine is very high, which I haven't.
Oh, right.
I don't exactly understand why that's high. I know B vitamins. Have you ever been low in your B vitamins? Have you ever checked your vitamins? We don't check B12.
I don't remember. I don't.
Oh no. Okay.
I don't feel like it was a red flag, but I don't know for
Okay.
sure.
Have you had it checked in the past?
Is it part of a regular profile? No, I don't think so. Yeah.
We don't really check the B12 because we could, but we don't usually check it. We could actually check it today. I mean, that's not a bad idea. Then we have a baseline, but I just wonder like why maybe your stomach isn't absorbing B vitamins as much as she seemed to eat a lot of vegetables.
Yeah, I mean, that would really surprise me to be.
Yeah. I don't know why your homocysteine is high.
Yeah.
You don't smoke. Do you drink a ton of coffee?
No, I drink a lot of tea,
Tea?
but I
Shouldn't
don't drink
increase
very
it.
much coffee except when I'm traveling.
Yeah.
Like,
Yeah, your homocysteine's high. I also, your thyroid. You're gonna have to see your primary
Oh.
care doctor about that
Okay.
too,
Okay. Yeah.
which we'll take care of. So what I'm gonna do is I'm gonna type up all of these recommendations. I'm gonna give you. I started typing up before, and then we kind of got derailed a little bit. But I'm going to type up all of these different things that you need to do, and I'm going to personalize this for you a little bit more than I was doing before. And what we're going to do is going to give it to you. You're going to do the best you can with it. You'll stay in touch with me via email if you have any questions, and then we'll have you back. Usually we have a follow-up visit, but since you live in California, why don't we have a follow-up phone call in 6 weeks or so, 6 to 8 weeks. Definitely it's better or more effective if you happen to be in town, but if you're not in town, we'll jump on the phone for a little bit, and then you'll come every 6 months for a little while, and then 2 weeks before you come back for your 6-month visit, you can get the labs drawn like you did. That was pretty smooth.
Oh yeah, that was good. Yeah.
Easy. Okay.
And
So-
do people see changes like on that next visit? Is it like that fast, or is it like like in the next 5 years? And you've been around for 5 years. So
No. So the good news is most of the stuff that we've been doing. Actually, here's the results. So within 6 months, the average patient in our clinic, if you type in all of these numbers into a dementia risk scale, or there's different risk scales out there from Australia to America. There's all different scales. Within 6 months, we see significant or statistically significant reductions in calculated Alzheimer's risk. Now, does that mean we're preventing Alzheimer's? Well, I don't know. We don't have the brain imaging. We're not doing imaging on you before and after. That's very expensive. We don't have funding for that. We just started to get a little funding. Within 6 months, these are the measures that improve. Dimensional change card sort, flanker, and processing speed are the ones that improve the most. Processing speed, yours is already pretty good, so I don't anticipate it getting that much better. But actually, the FAS, all of the things that you actually didn't do as well on as you could have, you're kind of amenable to improve upon.
Yeah.
So yes, I do think that we could improve. Now the tricky part here is people with different genes respond differently. So you have
Right.
so people with the ApoE3 gene, you have this 3-3 here. People with the 3-3 gene tend to improve their LDLP, which you have abnormal, tend to improve their dietary patterns, which is great. So you probably will respond. Your animal naming, all of these different things in our group of people just like you tended to respond.
And can you tell anything about the type of dementia that people are at risk for? Are you only focusing on Alzheimer's? What is Alzheimer's?
Yeah. So the only people that we see in this clinic are people with normal memory, but with a family history of Alzheimer's disease, and that's how you fit. You're a little confusing because your dad had vascular stuff. When I first met you and I started talking to you more, I don't know if this is just clinical experience or my gut. To me, I would say you're a little bit more in the vascular bucket, which is better in some ways because that's a little bit easier. You said you're physically more similar to your dad. Your labs look a little bit more similar to a vascular. Your cognitive function, your memory is good, and your animal naming was good. You have no preclinical, you have no very early changes in memory that worry me. So your executive function being a touch lower than it could be, but not abnormal by any means. If I had to guess, and this is all it is, it's just a guess, I would say you're a touch more at risk for vascular cognitive impairment in the future than Alzheimer's disease.
But would that be true? A lot of people coming in, and I mean, my experience. So you always, read about things, and it's like, well, see a neurologist and get the test. But so many people I know who are just out there, they're just like, Dad can't remember this, and Mom is, doing this behavior, and it's great. But they never really know, like, is it Alzheimer's? Is it vascular? In fact, I don't really know with my dad. Do people come to you and they just?
We try to distill it out. We try to distill it out as best as possible, but all we can do is use our evidence. Take what you tell me in the history as best as we can. Take what we see here, which is you, right? This is you under the hood, under your brain. That's the cognitive test. It's you inside with the body metrics, and it's you inside with the blood. This is as much information as we can get without, invasive tests or spinal fluid or brain imaging. And all we can do is as good as we can do. We're going to try to reduce your risk for vascular cognitive impairment. We're going to try to reduce your risk for Alzheimer's based on the best available evidence. And in doing so, we're probably going to make you a little bit more healthy and probably help with cardiovascular risk too. But there's no definitive way to figure out what may be down the line for you in the future. For example, if we got a coronary calcium score on you and it was positive, I would say, oh, okay, maybe you are at risk in 20 years for vascular stuff. Well, you don't need that right now. You're just, the best that we can do is take this little diagram here, which looks like a spider web and looks a little complicated. But we take your lipids and we take your metabolism and we take all these different areas. These are your biomarkers. We tell you to do all these different things using these things, using potential supplements or diet or exercise or general health changes. We stratify it based on your genes. And we tell you to do all of these things, like I'm going to do for you on that long Word document. It's going to be about 5 pages long. And these are the results that we get. So this is the best we can do in 2017, 2018, 2019. In the future, we're going to be even more sophisticated. Give us a year, maybe a year and a half.
We'll say future, and they mean like 10 years in the future.
No. This is right now is pretty futuristic. 5 years ago, when we talked 5 years ago, never in a million years would I have said this is what would come out of this clinic. I had no idea what was going to come out of this clinic. This is all data. This is all data, and this approach has evolved.
And how many people have gone through now?
So we've had 650 people come at least one time, and that's 250 people with cognitive impairment, dementia, and about 400 people with no cognitive impairment whatsoever. Of the 400, about 280 of them have been back for more than one time point that we have longitudinal data on. And this, I believe, is 168 participants. So this data. So as our data grows, our numbers will get stronger.
And so these work prevention in the name of the clinic, and so that was like major taboo, right? When I was sort of, you can't, you're just screwed. Like millions and millions of people are just screwed out there. But so tell me, like, why? But you've gone out on a limb and you're calling it like prevention clinic, like you use some analogy to like heart disease or something. Right? It's like.
So can anyone ever definitively prevent a heart attack or a stroke? No. You can try to by doing lifestyle changes, drugs, whatever it is, right? It's the same thing with Alzheimer's. You can't ever definitively prevent a stroke, a heart attack, or Alzheimer's, but you can do things to reduce risk. And not using the term prevention, it's just a semantic question. Just because I say I'm going to open up a cardiac prevention clinic, if you have people that go to your clinic and then have a heart attack later, should you take the word prevention out of your clinic? No, it's a concept. And the concept that Alzheimer's prevention are two words that can be used in the same sentence, absolutely that time has come. You know, I mean, heck, 5 years ago, forget it. Well, 10 years ago, I got tomatoes thrown at me. 5 years ago, people would roll their eyes. Now when we can show real data, and then once we publish this in the next year in bigger numbers and bigger journals and, you know, charting things out, well, what changed? Right now, this is just, here's this 5 pages of things to do. In the next epoch, we're going to try to figure out, well, what was it? Was it the B vitamins? Was it the exercise? Was it this? Does it work better in women? Does it work better in men? Right now, we think, and we've seen preliminarily, that our approach may work better in ApoE4 positive patients. What we need to do is get another 100 people, do really fancy analyses, compare our data, where we have a longitudinal cohort where we're doing this approach, and compare it to, since we don't have a control group, we want to compare it to data that is out there, like, you know, people that have taken the NIH toolbox every 6 months for a few years, but no intervention. We want to look at their data over time and look at our data, and does our data go up and then stabilize? That would be my hypothesis, and that's kind of what I see clinically. And 6 months, believe it or not, I think people doubt this. Is like you just said, is something going to change in 6 months? Absolutely. 6 months, and then usually it stabilizes. 6 months to a year is probably the best results. 1 year is what I would say ApoE4 positive patients sometimes need, that year to kind of respond a little bit better. Sometimes maybe there's other genes, but some people in 6 months completely turn things around. Other people in a year, that's when they kind of need a little bit more time.
And then so like in 5 years, now you're able to track people even more longitudinally and see more change, but you won't, you won't know. Proof will be like in the pudding. Some people will.
Well, we're starting really young, so
right.
just figuring out if 30, 40, 50, 60-year-olds develop Alzheimer's, you need to follow them for decades.
Right.
Okay. What we're going to do as our next phase are incorporate brain imaging, where we do MRI, glucose metabolism PET, which is FDG PET and amyloid PET, before an intervention, and then we do an intervention and probably rescan it 1 year. Right now we just have funding for a small group of women between the ages of 40 to 65, one time, but no post-imaging. What we need to do is keep scratching at the surface, and there's just no grants that even exist for some of this stuff. So it's a little bit hard.
Yeah, that's what makes it all so amazing. And do you expect that there'll be like different interventions at different ages? So like, so I asked you before, like, maybe at 35 I come in and I have a similar or different profile, but then like postmenopausally, there might be a different intervention.
Oh yeah.
For
every 6 months we retool
over each individual, not even blanket.
It's called N of 1 medicine. Yep. We treat you compared to what you were then and what you are now. We're not going to treat you compared to the 1,000 people that were in that trial that weren't like you at all, because it was 1,000 people on average. So this is kind of the new field of precision medicine. In a couple of years, I hope, we're going to be adding much more genetics, but it's tricky. I hope we can one day put all this information in a computer, and instead of me typing, right now for the next 20, 30 minutes, I'm going to type out some recommendations for you.
Okay.
I hope that one day we put this into a computer and it spits it out for you. But we're still writing the instruction booklet on that. So.
Well, the other real interesting thing is just when I was reading about what y'all are doing, working the whole technology, that you have such a big tech team and looking at ways to make these things more available to more doctors, and so people must get in touch with you.
We average about 3 to 4 doctors or healthcare providers per week get in touch with us, and actually this video will be on that website, because people say, well, what is an Alzheimer's prevention visit? Well, this is it. Congratulations. This is the first Alzheimer's prevention visit that's been documented on camera. So we appreciate you doing this. Good for the field. You'll have lots of doctors hopefully changing their practice because of it.
Are they largely neurologists or all kinds of?
Oh gosh, everything.
Really?
All walks of life.
Huh.
I can search through it real quick, but I have a list of everything. But honestly, I'm not. No. I would say 10% are neurologists. Maybe a lot of primary care docs. Let me just give you a quick quick rundown. Everything.
Yeah.
Psychiatry, medicine,
Right.
family practice, a little bit of everything.
And so do you get people who call and they're like, well, we think there's something wrong with mom.
Mm-hmm.
That's not where you are.
Not
yeah.
our clinic, no.
Right.
And sometimes people slip through like that, but while I empathize and want to help, and that's what I did for many, many years, we have to keep our eye on the prize. And no cognitive impairment plus family history of Alzheimer's. We have to well characterize 250 people. You know, right now we're pretty close to that, but we just need to then analyze the data. We got to get clean data, so it's not just hodgepodge of people that have different histories.
Right.
Yeah, we just want to keep things clean.
Right.
So we have a waiting list of over 300 people right now.
Really? Wow. Wow.
300.
Wow.
I saw someone this Tuesday. She's been waiting for 11 months. Now the waiting list is longer. So I hope that the doctors are willing to do this. We're trying to put all the instructions on how to do this online, and all the cognitive tests. You know, the eye tracking test, the face name, the things you did.
So they'd be able to replicate the same kinds of things you're doing.
Any doctor that wants all the survey you took at home, the 40-minute survey, everything's free. Everything's available to doctors.
And will they be all be data sharing so that you can? I mean,
it's hard.
I mean, like the clinical trials, just stuff that you're feeding,
or it's hard to data share because if doctors are doing it in their clinic, they need IRB approval, and it's a little tricky.
Yeah.
In an ideal world, yes, we should all be sharing, but
Yeah.
in a clinic like this, it took over a year just to get the IRB approved. So it takes a long time.
Okay.
My last question for you. On a scale of 1 to 10, how aggressive or comprehensive do you want me to be when I type up the recommendations?
Oh, 10.
10.
Yeah, because like you dangle optimal there, and I'm like, yeah, I'll try for optimal. I mean, don't like say things that are just wacky things you think might, but like things if you really think it'll make a difference, like I just find it, Also, I feel like all these things, it might help like all my head. It's like how it's your body. It's like it's not just like my brain and versus my head. And it's like so. I feel like it's all for the good. I guess. I don't know.
Cool. Okay. Everything that we recommend is grounded in strong science and safe. Because the last thing I want to do is recommend something for a disease you may not get. That's the last thing. If anything has any safety worries, we clamp that off.
Okay. I realized there were three things when I was going through the intake that occurred to me that weren't on there, and I just was going to ask you, I was just curious why. So like it went into so much detail, right, about the early, test scores and different things. But there were three areas that weren't on there at all, and I was just curious why. So one, there was a little bit about social, right? Yeah. But now like social media and like time online, like I don't know if there's like, people are studying that and what its impact is on the brain and health, but it was like that area. Right. And then you did talk about like stress reduction, and it's like, like it's all that down, like meditation is like, I don't do that, but that's a big thing. That's like a deep like area I was just curious about. And then the whole area of sex completely like isn't on there at all. And like with the heart health thing, that's like becoming like a big thing. Right. So I was just curious.
Right. Let's see. I guess I'll start with.
Because your average person's not going to ask you that.
Yeah, no, it's okay. So those are great questions. So I guess the field is evolving, and we do the best we can based on evidence. Now, when it comes to stress, let's talk about stress first. So, as one of the things I'm going to recommend to you, you don't have as many hobbies, but you seem like you have a reasonable, engaged lifestyle, so that's good. If you don't, aside from the tips that you've learned, mindfulness-based stress reduction is the most evidence-based type of stress reduction out there for brain health, mostly geared towards cognitive aging, but there are some positive outcomes. Now, when I look at your cognitive tests, your processing speed is pretty good, and that's something we usually see that's maybe a little off. But your sleep is really good. Sleep helps with processing speed. I'm going to potentially, as a soft recommendation, say if you're interested in stress reduction, I'm going to give you a link in a program that's exactly been studied in a rigorous evidence-based way. And I'll give you information on that. When it comes to social media, it's a little bit confusing. There's just not rigorous data out there. Socializing is good. I'm going to recommend socialization, adult education classes, but for someone like you, it's a little bit less. You're already kind of in it. You're learning new things. You're writing.
I was just sort of curious what the data, like what if there is, if it's looking at that and it's like, is it a negative, right, or a positive?
Yeah, social media is confusing. And then sex, I'm not sure. Got to do some research. I'm going to consult Dr. Google on that one.
Because like with the heart health care, that was like a whole big like area, and it and it makes a lot of sense. And
I have not seen any data, so I don't know.
Don't tell me to take up a musical instrument. It's not going to happen.
I'm going to ask you politely to take up the music.
You can make a soft conversation about that. Okay, and so like, to the question people say, like, is it too late? Like, when is too late to try to make changes?
I believe never too late. I mean, yes, the earlier you do it, the better a person does, but I mean, it also depends on your family history, and even 10 years before the average age of your family members, I don't think it's too late. Even 2 years before. I mean, before symptoms is never too late. Even with mild symptoms, it's not too late. I think any time is better than not doing anything. But by far, these things work better decades in advance, by far. And we're trying to show that. Like, I think what we're showing in our data, and we haven't published this yet, is people with normal memory versus mild versus subjective complaints. Normal people do better, meaning in terms of a response to our therapy. Even though they're normal memory, they can still improve labs and cognitive function. People with subjective cognitive complaints, like little glitches, do better than people with mild cognitive impairment. People with mild cognitive impairment don't respond as well to this stuff. They just don't. It's unfortunate. Certain people with mild cognitive impairment don't respond at all to this stuff. Other people do. And we haven't figured out why, because our numbers are really small.
That's interesting.
We need like a few more neurologists and a few more nurse practitioners in the clinic and another 1,000 patients, and all of this would be completely clear.
Problem with being a visionary, see the whole thing, and it's so much out there.
We're close. We're $5 million away from fast forwarding all this stuff, and $5 million in the grand scheme of $1 billion being invested in Alzheimer's research is like pennies. But there's no grants that fund this stuff, so we'll get there.
You need Bill Gates' son to get a little older.
Exactly. It's the way to do it.
Okay. Actually, I've asked you a bunch of these things along the way. So, in terms of, just can I ask you, for like the parade thing, like, so in terms of, like, I mean, broad categories, of advice, and I think I've talked to you a bunch about, what some of those are, and
you'll get in the Word document. You're going to get a lot of those too.
Great, and I'll prepare back a lot of that. I'm just curious, like, just in a broad sense, it's like, yes, obviously the optimum is getting a clinical precision, sense of what's going on, but what is it that you want the average person to know about preventing Alzheimer's or?
Knowledge is power. Don't be fearful. If someone is having symptoms, get evaluated. If someone's not having symptoms, know your numbers. Go to a doctor, get your cholesterol checked, get your diabetes checked, diabetes levels checked, get your homocysteine checked, get your vitamin D checked. This is not rocket science. These are like 10 labs that any doctor can check. And go to Alzheimer's Universe, take the free course on there.